In this video, we are going to be reviewing failed upper extremity cases on FOTO. So these are people that did not meet their expected scores by the conclusion of their episode of care as measured by FOTO. So the first one's case 1. We have 10 cases here. Primary complaint, shoulder pain with headaches and neck pain. 45-year-old male. It had been going on for 17 months, and the goals were set for 6 weeks out. Episode of care duration ended up being 2 months. He had no copay. He started off at a 57. He improved to 65 in 7 visits, but it predicted 73 in 10 visits. So again, he improved by 8 points, but they predicted a 16-point improvement with a few more visits. And so as we could see some of these, we're going to see all the same criteria, same things on the left on each one of them, and then the same categories on the right on each of these. So one of the things I do want to point out is that when we're looking at symptom duration, if it's there for 17 months, then we set a goal for 6 weeks. That symptom duration should give us a little bit of an indication of how long it may take for them to get better. There's not a set in stone rule, but if all of them, the episode of care duration is longer, then maybe we're not setting our goals for long enough with patients. Now, some of these people we may be setting goals. I didn't look at the ones that were successful. Maybe we're doing the same thing on those, and we're getting there. So we're trying to find out what would tell us that we're not getting there as quick as we thought. And so this one ended up being 2 months, and it still didn't get to the expected improvement. So make a few notes here. The patient ended up stopping care for an unknown reason. So that is something that did stick out, that the therapist didn't think that they should be done after those 7 visits. Probably we're going to go those 10 visits. But the patient did just conclude care at the end and just said they weren't coming back. First visit had manual therapy to the neck and shoulder and exercises for shoulder which produced good results between visits 1 and 2. And dry needling was beneficial on visit 1 as evidenced by what the person said on visit 2, but it wasn't done again until 4th visit. And symptoms seemed to be chased so they kept going, okay, now symptoms are here, okay, let's do this today. Symptoms are here, let's do this today. Instead of working on previously what they had worked on and focusing on the noted pathology. And they resumed needling to the original structures when they hit a standstill. Manual therapy is performed to the cervical spine, but no cervical asterisk sign. So the person recognized that the person came there for shoulder pain, recognizes the neck pain and headaches, and the neck is involved with that, but then didn't test to see if the manual therapy to the cervical spine was being effective. This was a salient feature of it. We want to know that if we're performing manual therapy to an area, that it's changing that area. Even if it's not changing what's distal, at least we need to know that it's changing where we're where we're treating. If it's not changing there, it's very likely not going to change anything distal. So here are the crossroads. I always want to say, okay, at what point in this care should we realize, okay, let's do something a little bit different that could have really changed the course of treatment? On visit 2, he said he was better from needling, and then it wasn't performed again. That does not seem to match the patient expectation. That, hey, I told you this helped, and then we don't hit that again. Now, there might have been good reason for it, but in general, if something's helpful, they're probably going to expect that again. And on our reasoning, we should probably try that again as well. Progressive, consistent treatment will help to find the holes on why someone isn't improving. So if we're jumping around, then it's hard to go back and say, okay, why isn't this person getting better? We're 2 months later, and we've just kept jumping around. We don't know, do they respond to something progressive? So let's go to case 2. Right lateral neck to fingers was the complaint here. Early 30s, female, been going on for 8 years. I didn't get how long the goals were set for, but the episode of care duration was 5 weeks, and financially there wasn't a copay either. They went from a 76 down to a 69 in 5 visits, but it was predicted it would just go up by 1 in 9 visits. Myotomes are clear. Cervical range of motion is full and pain-free, even with sustained overpressure in all directions. And accessory mobility is more hypomobile. um, in the cervical spine than the thoracic spine. So that's good. They're grading those. And ipsilateral costovertebral joints are tender and hypomobile in upper thoracic spine. So it is tender. It's more hypomobile in the cervical spine, but it's tender on the ipsilateral side of those costovertebral joints in the thoracic spine. So a salient feature here is upper extremity tingling without any symptoms with cervical overpressure is uncommon. That should really stick out, that wow, I had 10-second holds of overpressure on their neck at end range, and they didn't feel any negative symptoms. I mean, most people have some symptoms with overpressure of their neck that long, regardless of any other symptoms. I know I do. For them to have right lateral neck pain down to their fingers and have to say cervical range of motion is full and pain free, even with overpressure, that does not. That is somewhat surprising. So I would make a note of that. We have no way of knowing, did the therapist actually really perform that, or was that maybe they just put that in their note. But whenever you're seeing that, we want to, if we're not seeing that the neck is involved, and we're getting something that before just looking at the body chart would scream neck, that should make us take a step back and say, what's different about this patient? Subjectively, this person did improve a lot, but this didn't line up with her FOTO score. So the question is why? Did she feel she made it just less painful, but her function wasn't improving? Did she just answer it randomly? I'm not sure. One of the goals was that she could shoulder press 25 pounds. I don't know if this is the patient's goal or the PT or the physical therapist's goal. If the physical therapist thought that she could get to that, and she did not get to that, and so maybe if we'd have focused on that more, and told her, hey, once we get there, we should be able to be at your goal, so she could see the goal. That might have helped the FOTO score as well, because one of the questions is lifting heavy overhead there. Case 3, primary complaint is shoulder pain. Male in his early 50s, had been going on for 3 months. We set the goal for 6 weeks. Episode of care ended up being for 10 weeks. So again, longer episode of care than what we anticipated. $30 copay. 53 improved to 69 in 10 visits, and then regressed to 62 by visit 11, and was predicted 69 in 12 visits. So we got there. I think the therapist was probably hoping that they could see a little bit more, make sure that it stayed, but we regressed. Interestingly, in this one, at 3 months, the patients did fall playing flag football. So it was a pretty active person to fall and playing flag football. No immediate pain, but it started having a week later, which is common with whiplash. That can happen later. A cortisone shot a week before his initial examination did help, so that's also interesting. Cervical active range of motion is listed as normal without replication of pain. Strength is listed as 4 plus out of 5 for elbow flexion, internal rotation, and elbow flexion. Oh, no, shoulder flexion is also 4 plus out of 5. And then 5 out of 5 for extension and shoulder external rotation. For elbow and shoulder extension and shoulder external rotation. So progressive loading throughout the episode of care, from active assistive range of motion to dumbbell exercises. Here's some salient features. So cervical range of motion with overpressure doesn't replicate symptoms, but it does not mention whether there's any limitation or pain. So remember, we do not have to replicate shoulder pain to have the neck be involved when we're testing with neck motions for the neck to be involved. So again, I'm going to say that if we have shoulder pain and we have any limitation in the neck or pain at end range, the neck could be involved. And we need to make note of that. So when we go back and look there, we know, oh yeah, if they're not getting better, or they're not getting better enough, the neck was painful in end range. We should retest that, make sure that we can get them to full function. I don't know how much range of motion they had, because there's the active range of motion. There was an onset early of pain. I don't know how mobile the shoulder was. So visit 2, we have our first crossroads. There's no significant change after visit 1. There was no HEP given for the cervical spine, so that also says that may be a cervical issue. If we give something and they do it for even just a couple days, they should notice some type of improvement. And if they don't, maybe we got the diagnosis wrong. So whatever we give them first day, they should notice something by visit 2. And if they're not, we need to reevaluate. They won't always improve, but we need to look and say, should this have made a change? And if not, should we have given them something different? We want to be able to make a change before visit 2. People aren't wanting to pay. This person has a $30 copay and they didn't see any changes between visit 1 and visit 2. How many times are they going to do that? Visit 11. The patient is frustrated that he's a little worse. The previous visit he had hit his FOTO goal. Now he's worse and then he doesn't return. So he's gone up and now he's down. Where is this going to keep going? Now he's already over $300 into this and he's getting worse. I would probably not want to stay either. And it was a month later that his FOTO was worse. So I don't think they did it on that visit. He came one more visit and then he didn't return, and then we call a month later and found out that he is doing worse, and so that's why the FOTO goal wasn't hit. So at visit 11, it's essential to reevaluate to see if the diagnosis was missed. So we've been working on something for, let's see, how long? 2.5 months, and now the person is worse. What have we missed? If we're still confident it's a rotator cuff problem, then education is crucial. Fluctuation is normal with rotator cuff issues, and it's likely going to happen again. I don't even like to say, oh, this may or may not happen again. No, you're going to have shoulder pain sometime later in your life. The data shows this and our experience shows this. Don't worry about it is what we need to make sure they know. It is dependent on load. Sometimes they're able to identify what caused it, sometimes they're not. We have to make sure that they understand that this is going to happen and then what to do about it. If we keep them, if they saw us every week or every month of their life, they're still going to have fluctuations. We need to make sure that they're prepared for that and they know how to get out of it. And if they don't know how to get out of it, if they can't manage it on their own with our education, come back and we can help them. And if they're not sure about that, or you're not sure you're going to be able to help them, tell them other options and why you would or would not recommend them now or in the future. All right, case 4, primary complaint is shoulder pain. This is a male in his mid-50s. It's been going on for a few months. Set the goal for 4 weeks. Ended up taking 6 weeks. No copay. Went from a 65 to a 69 in 7 visits. But FOTO thought they would get to 77 in 9 visits. So we had some improvement. Not as much as would have been expected. Pain occurred after a fall. A little bit weaker in the rotator cuff. Cervical flexion, active range motion. Elicits tightness in the shoulders. Cervical side bending, rotation are both limited, so it's good that they made note of that. Accessory mobility elicits local pain, so in the neck between C5 and C7. Speeds test and empty can are both positive. And neuroexam of dermatomes, reflex, and myotomes are clear. It doesn't say how long they held the myotomes or anything, but we're going to trust that they held them for at least 5 seconds and were aggressive with them. Treatment focused on cervical manual therapy, glenohumeral joint mobs, and repeated spine motion and loading the upper quarter. So manual therapy to neck and shoulder, gave home exercises for repeated motions of the spine, and then loaded the upper quarter. So fall is a traumatic. The traumatic mechanism of injury is a fall. It didn't have any symptoms for over a week, which is odd, but sometimes rotator cuff issues can act like that. Normally those are your overworked rotator cuffs, but still it could be rotator cuff. Limited cervical mobility and range of motion is definitely a salient feature. And another salient feature is they seem to address all the impairments treatment did. So crossroads, visit 2, patient returned with no improvement, so focus is changed to C-spine and is treated with manual therapy. Very appropriate. You give them something shoulder, they don't improve, then we change to the spine to see if we can, just like we talked about in the other case, if they come back with no improvement, maybe we missed it, we need to address something else. The second crossroads, visit 6, his remaining symptoms didn't improve after last session, so examination which was performed, which is again is correct. Median nerve glides are added. So when they're not improving, we need to then readdress it. Okay, we've been improving, we're not improving enough, why is that? So again, overall this case addressed the primary issues that he was having. Or the primary impairments, I should say. He wanted to conclude care because before it was recommended and before it was anticipated by FOTO. So again, remember, he thought that he wanted to be done after 7 visits. The FOTO thought it should be at least 9 visits. There should be 9 visits, and he would have gotten better. I'm not sure what could have been done better in this, just based off of the note. Seemed to address all the impairments. Unfortunately, he stopped early, so we don't know if he would have made that last little jump at the end. So front of shoulder that goes up to the neck. That's how the patient described it. The male in his early 80s, been going on for 1.5 to 2 years. And then goals are set for 4 weeks. Episode of care is only 2 weeks. And it's a $15 copay. And went from a 50 to a 53. And those 5 visits over a couple weeks, it was anticipated it would go to a 61 and 11 visits. So symptoms were in the digits 2 and 3. They would feel numb sometimes. Contralateral side bend elicits shoulder pain, and the shoulder has limited range of motion and weakness with strength testing. He did feel a snap in the front of his shoulder when using a pitchfork, and it got better, and then 6 months later it happened again, and now we're a 1.5 to 2 years thing, and now he's still been having pain, so now he's here. Cervical and glenohumeral joint manual therapy are performed in each session, except the first. So we only had 3 sessions of significant treatment before saying it wasn't getting better. So remember, session 1, no manual therapy. Session 5, he comes in and says he's not coming back. So it was only sessions 2, 3, and 4 really had manual therapy to make a change. But he was hopefully doing his home exercises in that time. Numbness, so salient features, numbness in ipsilateral fingers, hypomobility and limited neck range of motion, and shoulder pain with ipsilateral cervical side bend. So that is a huge screaming that this is primarily a neck issue. Visit 2, when he comes back and is known better, we need to spend more time on treatment than we did in visit 1, obviously, and then determining which asterisks improve his cervical treatment, which improve his glenohumeral joint treatment. Something I notice here is that we need to make sure that they can see what improves with treatment. Not just overall are you better, but what specifically is better, and that's where our asterisk signs really come in. Case 6, elbow and shoulder pain, male in his mid-50s. He does a lot of lifting, like heavier things for his jobs, a manual labor type of job, and he also lifts weights and swims for exercise. So getting his resistance training, cardiovascular, we love to see that. Symptoms going on for over 6 months. And we said goals for 6 weeks. Episode of care goes 8 weeks, no copay. Went from 55 to 76, which is really good. That met it. And then he regressed to 67 by the 7th visit, and he had a goal of 71 and 11 visits. So diagnosis is lateral epicondylalgia and biceps tendon pain. Lacking 14 degrees of elbow extension is a huge flag. It has elbow flexion listed within normal limits, but I've seen capsular patterns where a capsular pattern is flexion limited more than extension. I have to pay detailed attention to that one though, because if there's 20 degrees limiting on elbow flexion, they still have quite a bit of elbow flexion, and it may seem like it's all right. And that would be more than 14 degrees that they're getting there. And normally I see them a little bit closer, so maybe they're only lacking 16 degrees on flexion, and it's much more obvious that 14 degrees on extension. So I question whether it was really normal. I want to make sure that I'm overpressuring it repeatedly and turning that radius, and to see, do I get any symptoms there to really know that it's pain-free. Interventions are stretching and strengthening and I-stim to the elbow. No joint manual therapy is performed. They have lacking 14 degrees of elbow extension, and the person is in their 50s. Both of those scream joint issue. And no notes of whether interventions are helping the primary impairment of limited elbow extension. So it talks about they're able to do more, talks about that they're getting stronger, it's feeling a little bit better, but nothing about the primary impairment, which we would want, should be documented every session. Elbow extension is improving or it's not. Further, intensity of exercise in clinic did not match the intensity of activity at home. By the end, he's lifting 10 pounds in the clinic, yet he lifts weights in the gym. He's surely not lifting only 10 pounds in the gym and only lifting 10 pounds at work. So he's doing a lot more out of here than he is in here. So we're not really testing how is he doing. So Crossroads, Visit 2, we needed to assess the primary impairment again. We need to see if we made a difference. If not, something needs to change. I don't care how he feels between visit 1 and visit 2 if the primary impairment didn't improve. That I would change what we were doing if we're not improving that primary impairment. That is a huge impairment of lacking 14 degrees. Patient had regressed on FOTO on visit 7, not improved enough. The primary impairment was still because he hadn't, likely because that it hadn't improved all the way. Something to get people feeling better, but if the primary impairment doesn't improve, they're going to regress. And we're still not loading enough to really know how it's doing. We could have caught that earlier, and if we'd have loaded them more and then maybe seen, okay, this is where we're at, and this is where we need to be. But there didn't seem to be a sharp enough progression in the exercise plan. So this person also had shoulder pain. Looks like I forgot to write that there. But he was a male in his mid-60s, 4 months. Symptom duration goes for 6 weeks. Episode of care duration went a little bit longer at 9 weeks. No copay. Went from 55 to 67 in 15 visits. We almost got to that 70, but that was expected in only 11 visits. So a lot of notes on this one. The next page will have the salient features and the crossroads. It's occurred after a lot of overhead work. It improved and then worsened again, and he can't sleep in the recliner or supine because it causes a lot of pain. That is a very, I'm sure I put that under salient features. That position is quite difficult. It is painful for him. But he wants to be active. He was using a rowing machine and playing golf before this. He had normal glenohumeral joint mobility and non-painful stiffness in the cervical and upper thoracic spine. Upper thoracic, again, T1 through T4 is crucial for the shoulder. Cervical range of motion is not measured. So they didn't look at cervical range of motion, but they did test accessory mobility there. Said it was diagnosed as rotator cuff pathology, but there's no MRI or ultrasound, so we don't know. Laboral tests are negative. Visit 2 started cervical and thoracic manual therapy. So we started there in pain-free exercises. In the middle of the episode of care, he had a fall off a backhoe, which is pretty significant, but he seemed to have recovered within a couple weeks and didn't have any negative features from that. And that was before they tested FOTO. He did have an MRI in the middle of the episode of care, and it showed a small supraspinatus tear, which we'd expect somebody in their mid-60s that they're going to have that, whether they have pain or not, and even more likely if they do have pain, that they're going to have some type of tearing in the supraspinatus, most commonly torn one. Halfway through the care, the patient didn't think neck manual therapy was helping. Glenohumeral joint manual therapy is continued. Joint signs are found in the cervical spine and T-spine. That is very significant, and they're not found in the glenohumeral joint. But the glenohumeral joint was treated significantly. Why are we testing it and saying it's normal if we're then going to treat it as if it's not normal? And there's no cervical asterisk sign, so this is another salient feature. We're going to treat something a lot, but not have an asterisk sign for that to see if are we doing enough to actually change the area that we're treating. We're treating the neck. We need to know, are we changing that? And we didn't have range of motion, and we didn't have any asterisk signs with that. Rigorous exercise performed for the shoulder external rotation abduction, like it should be for rotator cuff, and it was pretty rigorous for that. I assumed that it was given to him to do it at home, and how to read those symptoms. Visit 2, there's a crossroads. It's noted that the exercise was performed without symptom exacerbation. If we're treating the rotator cuff, there should be some symptom exacerbation. It looks like we got there later, but we want them to know, like, yes, we're all right with some pain here, as long as it's not in the next morning. The patient does not think a hallmark of treatment is helping. So visit 10, he says, I don't think this neck manual therapy is helping, so it stopped. How would he know if it's helping or not? We're not testing, we're not doing asterisk signs right after to know if it's helping or not. So we got to get cervical asterisk signs of range of motion, active or passive with overpressure, and shoulder active range of motion. We have to retest those, and also a functional movement, something that means something to them, so we can see what does it help and what does it not help. If it does help the neck, but we're not getting any benefit with the shoulder, well, maybe it doesn't need to be treated for the neck. If we're not getting any in the neck, maybe we're not doing a good enough job with treatment, or maybe there's something wrong there that is not going to improve with conservative care. Visit 15, I don't know what conversation was had. but we need to make sure that we educate them on a rotator cuff repair. If they've had imaging saying that they're still having pain, they're going to think of this. They're going to know people that have had this. Another physician or healthcare provider is going to bring it up. They're going to wonder if they should have it in the future or not. We need to make sure that they know that there's going to be exacerbations, and they're always welcome to come back to us. So this person had shoulder pain, female in her late 50s. She's quite active. Symptom duration 7-8 months. Set goals of 4 weeks. Ended up going 6 weeks. We still didn't get there. Financial is $30 copay. Went from a 55 to a 62 in 6 visits. Anticipated 70 in 11 visits. So it seems like we were on track to get that. She reports having carpal tunnel syndrome, and that does worsen during treatment. The C-spine range of motion is not evaluated, but there is mild hypomobility of the C-spine with PAs, but no pain with these. So there's no pain, a little bit stiff, and we don't look at neck range of motion. C6 myotomal weakness. It's mildly weaker, but it does demonstrate weakness. And X-ray shows bone spurs, but there's no MRI of the shoulder. Manual is initiated on visit 4. So it's just exercise before that. Visit 5, an asterisk sign of reaching out to the side is improved with C-spine manual therapy. So they treat the neck and then they tested shoulder. Really good job. And it wasn't improved with glenohumeral joint manual therapy. But there was no cervical spine HEP given. It was just updated with more challenging exercises. So we found something that helped an asterisk sign, and then we didn't give an HEP to follow that up. We just kept with challenging exercise. And exercise is good, but if it's not addressing the primary impairment, it's not going to be as good. Visit 7, the patient is doing quite well, it says, but then 2 days later, she self-discharges, cancels the appointment for the next week, and we don't have a reason why. So salient features, what really sticks out to me about that? It's self-reported carpal tunnel syndrome. So all we know is that she has distal symptoms and we have shoulder and hand symptoms. And there's no mechanism of injury. And the neck does not have range of motion performed. So no mechanism of injury, distal symptoms, we've got to be looking at that because that is a strong possibility. And then when we do look at it, it is hypomobile, and there's also C6 myotomal weakness. And treatment eventually does demonstrate improvement with the neck, but we don't follow that up to actually make real gains, not just temporary gains with our manual therapy. We need to do that with an HEP. So Visit 5 did a good job of reevaluating, testing asterisk signs with the shoulder, but again, when we find the primary pain generated, we need to focus our attention on this and make sure the patient understands why the attention should be there, and make sure that translates to the home activities, their home exercise program. So when we find that, we need to let them know what that means and why we're changing gears there, and not just say, okay, that was great, and then keep with the same plan that we were doing that focused on shoulder that wasn't making enough improvement. Case 9, almost there, shoulder pain, male in his mid-70s who recently had a lumbar surgery 3 months ago. And goals are set for 6 weeks, episode of care is 7 weeks, went from a 50 to a 62 in 12 visits, didn't quite get to that 67 in 11 visits. Patient is quite active with riding a bike, even though they had surgery not too long ago. On their back, shoulder passive and active range of motion are limited. The cervical spine is not evaluated for range of motion or accessory mobility. They're just focused on the shoulder. His pain improves throughout, which correlates with the functional improvement he had on FOTO. So pain does improve, and so does FOTO. Throughout, didn't get to the goal still, but it did improve. But he did not reach the expected outcome. He was unable to do much exercise in standing, so he's always doing sitting exercise because of his lumbar surgery. I guess he felt better, even though sitting causes more pressure on the discs. Visit 8, patient says he's planning on having an appointment to consider an arthroscopic procedure. And he was told unequivocally that surgery will not help improve his passive range of motion. It was a stiff end feel, and he was told that having a surgery to remove the bursa is not going to help that. Visit 12, last visit. He's feeling much better, but he hasn't met the strength goals. Salient features, passive and active range of motion is still painful at end range. Strength goals not met. Cervical spine is never evaluated. So Crossroads Visit 8, he's going to talk to a surgeon. We need to make sure we preemptively talk about that. What do we think about that? And maybe it's a good option. We just need to make sure. For other people, I don't think it was for him. It looks like we need to make sure that the person understands what our opinion is, so they're not just going to a surgeon who's just going to look at an MRI and not do any physical exam and try to correlate that with what they're seeing on imaging. So visit 12, the patient is feeling good and conclusion of care is agreed upon. So last visit, they both agree. Long-term discussion should have occurred about the importance of progressive resistance training. It might have. It didn't say we didn't do this, so I don't know. But to prevent worsening from the future. The conversation should also consist of when to come back here, if so, and how to self-manage when symptoms return, not if they return. Very likely he's going to have some issues in the future, so we need to make sure that is discussed. And it may have been. I just don't know. Shoulder pain, last person, male in his early 30s and is former military. 1.5 years ago, symptoms started. Goals set for 6 weeks, go for 8 weeks. Episode of care duration, no copay. It went from 57 down to 52 in 14 visits, but it was expected to go to 70 in only 10 visits. He has stabbing, sharp, and achy shoulder pain, and also grinding. Grinding started 12 years ago. Pain didn't start until about 1.5 years ago. Neck pain with cervical range of motion, and reduced shoulder pain with cervical PAs. Ipsilateral C6 dermatome decrease. C6 myotomal strength is not tested, so we don't know if the myotomes would have lined up with the dermatomes findings. Shoulder abduction and external rotation is weak and painful. Decreased shoulder active range of motion, but passive range of motion is not tested, at least not documented. Manual therapy is performed in the neck, but exercise to shoulder on the first visit. Visit 8, patient reports he will be having surgery in just over a month on the bursa, bone spurs, and biceps tenodesis. Most sessions involve cervical manual therapy and glenohumeral joint manual therapy with resisted exercise to the shoulder. Salient features. There's neck pain with cervical range of motion, and it reduces shoulder pain with cervical PAs. Ipsilateral C6 dermatome decrease, shoulder abduction, and ER is weak and painful. Those are the salient features. The crossovers at visit 3, glenohumeral joint manual therapy is initiated, along with cervical spine manual therapy that had already been performed. This is the session we should determine which one helps which asterisk signs and how much it helps them. So we need to have a few asterisk signs, neck and shoulder, passive, active, functional. And then after we treat the C-spine, we test them. After we treat the glenohumeral joint, we test them. That way we can find out which ones are beneficial for what. And then they know, because what if never treating the shoulder actually helps it? This person might be having a surgery on findings, and it's all driven by the neck. We don't know. The only really thing that we found that helped it was neck manual therapy. So that's where it's important to be consistent with our asterisk sign testing. So the summary, 2 main things: consistency, consistency, consistency. Testing asterisks. So we want to make sure we have multiple asterisks, and we test them after our intervention so we know what helps what. If we are not testing them enough, then we don't know which interventions help which things, and we're just hoping. And when they get better, we think we're awesome. When they don't, we don't know why. So we have to have that consistency, and then they also know what's helping and what's not. So it helps us in our conversations if they want to consider anything more invasive. And then we need more progressive measurable exercise. If we are jumping around each time, we don't know, are they getting stronger or are they not? Is their tissues tolerating more or are they not? We just throw more different exercises at them each time, and we don't know, are they progressing through them? That's why we always talk about progressive resistance training. We need to make sure our exercises are progressive and measurable. And then remember, cervical range of motion doesn't have to replicate symptoms to be relevant. I put consistent, I meant relevant. Cervical range of motion, if there's any limitation in range or there's any pain with it, it may be contributing or the primary pain generator to their distal symptom. And we can document that it doesn't replicate their familiar symptom, it produces just local symptoms, but we need to work that out. That is an impairment that we probably need to treat to see if it helps. We do need to grade our impairments, but we probably should treat that to see if it helps, especially if we're not hitting home runs with our other treatments. And all these people weren't home runs, they're the ones that were failed cases.